Okay, so this is where we left off in class. Thanks again for being willing to let me just record this since we ran out of time. Again, this is not going to be really heavy content, but it's going to be stuff that's important. So one of the things that's important to understand is what you need to ask a patient when you do your GI assessment. So I need a little bit of a history. I want to know, how often do you go? What is your normal bowel pattern? What time of day do you go to the bathroom? How many times in the day do you go to the bathroom? Has there been any recent change in what your stool looks like, in its consistency, in its color, in its frequency, in its texture? Do you have any elimination problems or history of bowel or elimination problems? And do you use anything to help you go to the bathroom? So are we looking at patients who've got a daily history of laxative use? That's really important to understand. We're also going to do our assessment. So if you remember from health assessment class, you're going to do your assessment in a certain order. So you're going to inspect first. You're going to use your stethoscope to auscultate in all 4 quadrants. You're going to percuss, and then you're going to palpate last. And the reason why we palpate last is in case we're, moving things around. Sometimes we can get false bowel sounds from that. We don't want to have false bowel sounds. We want that to be as accurate as possible. So some of the common diagnostic tests, and again, I know my head is kind of floating around here. I don't have a good place to put my head, so hopefully you can kind of see on your own slides. There's a couple of different ways that we can look directly, or the provider can look directly into the colon, and that's through a colonoscopy. That's done with a scope that's gone up the rectum, and it gives a direct visualization like you can see right here in these 2 pictures. The one on the left is what the inside of your intestines should look like, and I often tell students that if you look inside of your cheek, so turn your cheek kind of sideways, that's what the inside of your intestine looks like. The one on the right has got a couple of things going on. Here, these little holes here, those are called diverticula. They're little outpouchings where food and debris can get caught. They can become inflamed and cause a lot of pain and actually rip open, which is kind of a major problem. There might be some debris here. You can see there might also have growths or polyps. So all of these here on the colonoscopy, sigmoidoscopy, and EGD are just different ways to visualize the inside of the GI tract. And EGD stands for esophageogastroduodenoscopy. It's a really long word that just means that you're going through the esophagus with a camera. The patient's lightly sedated, and they go through and they can visualize the esophagus down into the stomach and the first part of the GI system. There's also some indirect ways that your book explains. Abdominal flat plate, which is just an x-ray, different types of ultrasounds. Again, I don't need you to memorize all of these things. We just want to make sure as nurses that we're educating our patient on exactly what the test is looking at. So if we're looking on the inside of the intestine, we're looking for direct visualization. What can we see? Those patients need to be cleaned out. So we oftentimes do a bowel prep beforehand. It does require some light sedation. People have to have informed consent, which means that they understand the risks associated with the particular procedure. And then we also sometimes would talk with our patients about what they'll expect when they wake up. So they might be a little bit groggy. We don't require sedation for indirect visualization. They may need to drink some contrast or some dye, or they may have it injected in an IV. Those are kind of the education pieces that we talk about. Earlier in class, I talked about this. That's the common occult stool right there. It looks like a little kind of a paper card. It's looking for blood in the stool. Sometimes blood molecules are so small that we don't see them with the naked eye, and so we have to test for them. Please be aware that there's also other tests that require a full stool sample. So again, we talked about that in class, so we have them defecate into the hat. We can collect it with a spoon or a tongue depressor. We just need a little bit of a sample in the cup, and we're going to send that down. We can see if there's any parasites, bacteria, any kind of fecal fat, something that would give us a clue if there's bacterial growth or some kind of digestion problem. Making sure that the thing that we want to teach patients is that they can collect that stool sample for the stool for occult or fecal fat or parasites any time of day. That doesn't really matter. But if they're going to have a test for occult or for blood, we want to make sure that they're not eating a bunch of red meat before the exam. That can give a false positive. So stool cultures, again, you're going to collect in the hat, like I said, send it off. That picture there is about all the stool sample that you need. One of the other things that we need to do for patient education is help teach and provide opportunities for normal elimination. So when patients are going to the bathroom, poop or scoop is just an acronym to help you remember certain parts of helping eliminate or promote normal elimination. So make sure the patient can sit upright, make sure they've got adequate hydration, offer them fluids frequently throughout the day, make sure that they have some privacy. Nobody likes to poop in front of other people. More we move, the more motility we have in our GI system, which helps move the stool down. So when patients are experiencing extreme constipation or trouble with constipation, getting them mobile helps tremendously. And then making sure that they're keeping track. Sometimes patients will keep a poop or a stool diary just so that they can remember when they last had a stool, what did it look like, especially if they need to report back to the provider any kind of stool patterns. Size, consistency, did they note any blood? Was their blood streaking? Was there any foul odor? I mean, poop doesn't smell good in general, but was there anything that was odorous out of the norm? And then did they experience any abdominal cramping or discomfort with that poop? This is sort of a picture. Some of you might have heard of a squatty potty. Optimal positioning is important, and you can kind of see the rectal vault here. Sometimes when people sit down on the toilet, they might have a kink right here in that rectal vault, and so bringing the legs up into a squatting position, you don't need to buy a fancy squatty potty. Let me move my floating head over here. What you really need to do is just put their feet up on a trash can, turn on its side, or just up on a little footstool. Sometimes that'll help them. I told you guys in class that I really love a good list, and so let me move my head. That goes for this as well. I want you to know how to help your patients poop. So drinking water, making sure they're hydrated, a minimum of 8-ounce cups a day. That's really not a whole lot. That's 64 ounces, not a lot of water, but at a minimum, that's what they should be taking in. Increasing their fiber, so fresh fruits and vegetables, especially large amounts of them, if they're consuming, will help to keep that stool regulation going. Getting good probiotic food, so you can oftentimes make your gut very happy if you eat a lot of cultured food. So yogurt is a great active culture. Limiting caffeine. Caffeine is a bowel irritant, so sometimes it'll cause diarrhea if people take in a lot of caffeine. Stress leads to bad poops, immobility or lack of exercise, and then helping put the feet up in that squatting position, that helps as well. So we're talking about a couple different things that we might see in alterations. So constipation and diarrhea are probably our most common ones. We'll talk about fecal impaction. That's like the worst version of constipation, where it absolutely won't move stool through the body at all. And there's a couple different things that we talk about on how to eliminate that. And then bowel diversions we'll talk about. So managing diarrhea, there's a YouTube video you can kind of watch in there. But we want to know what's causing the diarrhea. If we can measure the liquid stool, that can give us an idea of how much output they're having. And diarrhea can even range in consistency from something that's like that you can't see through all the way to watery liquid diarrhea. It might have pieces of stool in it and it may not. But here's the key that I want to tell you is we actually poop, pee, and puke our potassiums. But since this is primarily talking about poop, we poop out our potassiums. Potassium is a really critical electrolyte for cell function. And a lot of times when patients have diarrhea, they can manage that at home for a while by replacing their fluid electrolytes. So drinking some Gatorades, keeping well hydrated, and monitoring the amount of stools. What we get concerned about and what requires hospitalization is excessive amounts of diarrhea to where we're seeing an increase in their pulse and a decrease in their blood pressure. And we're also seeing a decrease in their potassium levels. So normal potassium level is 3.5 to 5. A lot of times we will start admitting patients to the hospital when we get down to 3 or lower on that potassium level. And the reason why is because potassium is a critical element for heart function and for muscle function. And so we can see a lot of cardiac dysrhythmias that are caused from potassium imbalances related to pretty excessive diarrhea. So that's one of the major things that we watch out for and why fluid and electrolytes are so important. The other thing that I want to tell you, we talked about the brat diet in class. Clear liquids are great. If the stomach needs a break, just give it a break, right? And the way we do that is just by resting the gut. They can take clear liquids in. That way they're staying nice and hydrated. Once patients are feeling a little bit better and they want to start foods back up, things that are bland and non-irritating are great diets. I know it says pediatric, but adults can eat a brat diet as well. We also want them to avoid certain foods, things that are going to be spicy, things that are going to be irritating, things that are high fat. Those tend to kind of irritate the inside lining of the GI system and move through a lot faster. So there's a little bit of controversy. I don't know if the word controversy is right, but there's a little bit of school of thought when it comes to managing diarrhea. So people don't like diarrhea. I don't like diarrhea. Nobody likes diarrhea. But sometimes diarrhea is the body's way of saying there is something in here that needs to get out. So not always do we want to stop diarrhea. It's not recommended to immediately start to use anti-diarrhea medication. Sometimes the body's doing its job by ridding itself of some kind of toxin or something that shouldn't be in the body. Maybe you ate a food with a bad bacteria and the body's trying to get that out. So we really want to save those anti-diarrhea medications that are listed there, like Imodium or Lamodal, for times when the diarrhea is excessive. And so that's why we want patients to monitor that. I do want to talk a little bit about anti-diarrhea. So Imodium is probably loperamide, our most common one. You can get it over the counter. Again, it should not be used for the first diarrhea episode. It really should just be used when patients are having excessive amounts of diarrhea. So this is a picture here of excoriated skin. This can sometimes happen when patients have a lot of diarrhea and they're wiping a lot, or if they're incontinent of stool, either one. We want to add a barrier cream to this. So that can be done with a simple diaper rash type ointment or some kind of barrier cream. And then also using wet wipes to clean the area after the patient has a bowel movement, just to keep that skin from being red and making sure it doesn't break open. Okay, I've always got to throw in a funny joke every now and again. So I'm running over my 10 minutes. So I got to hustle. Managing constipation. So you guys did a good job in class talking about this. Things that we can do is to increase fluid, increase exercise, increase fiber-rich foods, provide for privacy, and then getting them up and around, making sure that they've got good motility, good mobility. All of that will help with defecation. And sometimes people just need a little bit of time. It takes time to relax. It takes time to get the stool to move down. We do not want them to use laxatives every day. That is not a good solution to constipation. Oops, I'm sorry. Some of the most common ones here are Metamucil, so that can be taken. It's a bulk forming laxative, so it helps with constipation. And then occasionally, again, let me move my talking head out of the way, occasionally Bisacodyl, it's also known by Dulcolax. It can come in an oral pill or suppository, and those again are used to relieve mild constipation. Milk of magnesia can be used. Again, it usually works pretty quickly, so take it in the morning, and by the evening time that should produce a bowel movement. You just want to watch for abdominal cramping. All right, last one here, we're going to talk about movement out of the way, is fecal impaction. And so the best thing to do is to prevent it, but sometimes medications or bouts of immobility might cause such severe constipation that it absolutely can't get out. And so there's a couple different ways. One is through an enema. And you guys will talk about enema insertion in your skills on-campus skills, and also a digital rectal exam. So digital removal of an impaction is very uncomfortable for patients. It's only done, again, when everything else fails, and this is done, you have to have a provider order. We just want to be careful. It can be very painful. It can cause trauma to the inside of the rectal vault, but it's done with manual insertion of the finger and then pulling the stool out. And it's very embarrassing for patients. So we just want to make sure that they've got good privacy and making sure that we're providing them with dignity and making sure that we're not, causing too much embarrassment. All right, establishing a bowel training program. We talked a little bit about getting patients on a routine, so making sure that we are doing all of the things to prevent constipation, and then allowing them to sort of develop when in the time of day would be a good time for them. So first thing in the morning, after meals, to help kind of train the body. When I eat, then I need to defecate, and sometimes that'll help with some of that as well. All right, last little section here is managing bowel diversion. So we're going to talk more in on-campus lab about colostomy and colostomy care, but these are just alternatives to getting stool out. They're surgically created, and this is called a stoma. It's basically where the intestine is brought to the abdominal wall and brought on the outside of the body so that stool can be eliminated. It's collected in a pouch. We want the stoma to be bright and red. That means it's got good oxygenated blood flow. That is a dead stoma. That means that they have not got good blood flow. One of the things that happens with this here is obviously they can't control the amount of fluid or the gas, and so sometimes it's really hard for them to want to do cares and to think about odor control. There's some diet modifications that we can make, so having them eat things like yogurt or buttermilk, those help with or cranberry, those help with some of the smells as well. All right, we're at the end. One of the things that I want to tell you is that most places have stoma nurses. So if you're lucky enough to have a stoma nurse, they'll come and teach about that. But you'll talk more about stoma care on the on-campus setting. This is about all I want you to know for now. Okay, I made it just under 15 minutes.